It's my pleasure to be talking about depth of anesthesia monitoring in the elderly or in the elderly patient. And when you look at the brain structure, we can basically, as we all know, distinguish two parts. You have the structural network and you have the functional network. Structural network is basically the anatomy. Functional network is how the different areas are communicating with one another, which they're doing at all time phases. Even when we're at sleep, there's still always these, let's say, the default kind of information loops ongoing. If you subsumize both of them, you can they make up the brain plasticity or the robustness of your brain. So the younger, the more robust, better the brain can cope with all new challenges, including learning, memory, but also addiction forming, maturation, and what is most important here for this discussion is a recovery from the surgical anesthesia trauma or stress. And we know that our brain or the plasticity of our brain decreases over time. You can see it here in the MR imaging. Younger patients, and younger is relatively 40 years old compared to a 92-year-old patient. You can see how the gray and white matter decreases when you compare both, and very easily to see especially in the increase of volume in the lateral ventricle, and if you compare both areas. So the substance of the brain, the robustness or the plasticity of the brain decreases over age, which is also well established. And this you can easily identify in the EEG and specifically in the DSA, because the power of your response in the EEG signals decreases accordingly. Here you can see the typical DSA for a younger patient with a very strong response in the spindle or alpha dominant area, 8 to 12 hertz, and the same in the delta area, really deep red for high, above 7 decibel power in these areas, compared to the older patient where you have very little alpha response and a not very much delta response too. So per the definition, you can already see in the DSA, this patient is in tendency more prone for burst suppression or for being more sensitive towards the sedative part of anesthesia. And we know, and this we have known for a lot of years, that post-operative cerebral dysfunctions such as delirium are very common. If you look at delirium, and these are the American Geriatric Society guidelines, delirium is the most common post-surgical complication, with up to 50% depending on which group you actually analyze after surgery. And it's associated with all negative outcomes from length of stay, increased costs, complications, cerebral complication, but also independent predictor for increase in mortality. But most importantly for us from the anesthesia perspective is that it's also preventable. And up to 40% in our own data, we have more than 50% prevented through adequate perioperative measures. And that is, of course, to some extent a call to action for us to avoid this. And what is important when you monitor delirium, or when you monitor delirium outcomes in general, is that it's not sufficient just to look at one outcome and then the other, but to also keep kind of the balance in between, because we know delirium is very much associated with pain, but also with nausea, stress, anxiety, agitation, and sedation. So in practical terms, for us, it's not an art to decrease post-operative pain. We just give sufficient or exaggerated amounts of opioids, and patient will be pain-free on an NIS scale. But at the same time, the patient will be sedated, might have nausea, vomiting, hallucinating. So it's always important to have the full balance of outcomes in order to also monitor this and not to over-titrate or under-titrate by any means. And we know that there's no single bullet solution for improving patient-reported outcomes or a post-operative delirium. It's always a bundle of measures that has to be introduced. And this is basically most information from the ESA guideline on the prevention of post-operative delirium, now called ESAIC, of course. And one of these recommendations from the ESA is usage of EEG monitoring intraoperatively to decrease the incidence of postoperative delirium. And there are two main randomized controlled trials that went into this recommendation. And those were the CODA trial, which was done in Hong Kong, a bit less than 1,000 patient, randomized controlled trial, and the Sudoku trial, which was done in Berlin, also more than 1,000 patients, 1,200 actually, and both had a blinded arm of monitoring. They used EEG, but the anesthesiologist could not use the values of the EEG, and an open arm where the anesthesia was, the information of the EEG was available for the anesthesiologist. And both showed a significant decrease in postoperative delirium when EEG monitoring was used for guiding or for driving the anesthesia. And they were published in 2013. Now, a newer randomized control trial from 2019, the so-called ENGAGES trial, very similar to the other two, slightly different from the patient collective. There was also cardiac anesthesia involved, but otherwise also over 65 and general anesthesia. So what the ENGAGES trial in 2019 found is that, and this is very important, of course, it confirms the results from the CODA trial, that EEG monitoring helps in decreasing the amount of anesthetics used, in this case only volatile anesthetics, because they only use volatile anesthetics. But the CODA trial also showed that by using EEG monitoring, you can decrease the sedative load with propofol. Then, interesting enough, and this is probably the most important information, that by using EEG monitoring, you can help to decrease EEG burst suppression. And this is especially important because burst suppression, as we know, is not a physiological state. You never have burst suppression in your sleep unless you are deeply hypothermic, deep coma, or have an anoxic brain injury, and then you have burst suppression. So avoiding burst suppression in most anesthesia cases, this is absolutely something that you should go for because this helps in avoiding post-operative delirium. Interestingly enough, also the ENGAGES trial showed that it decreased the 30-day mortality in patients that received EEG monitoring intraoperatively. Interesting, but you have to be careful of in interpreting these results or generalizing these results. What the ENGAGES trial did not found is that EEG monitoring helps to decrease delirium. And this is interesting because in the ENGAGES trial itself is a very interesting box plot. A box plot in regard to the delirium group, the SEBEJ group, and the non-delirium group in the usual care group. And you can see the burst suppression times compared in both groups. And you can see that in the no delirium group, you have a burst suppression time in median of 10 minutes. And in the delirium group, you have a burst suppression time of 48 minutes in medium. And this is, if you take a closer look at this, and Jim Cottrell and John Harting have done that, said this seems to be very much a significant difference. So the ENGAGES trial, you have to be careful in interpreting. Actually, it seems like it's more positive, an argument for using EEG monitoring than against. So this is kind of important to keep in the back of mind. There's numerous other literature all showing that the avoidance or decrease of burst suppression is beneficial in avoiding post-operative delirium. And especially the one from Bradley Fritz showed that for each additional 5 minutes in burst suppression leads to a 22% higher chance for this patient to develop post-operative delirium. And if you apply those numbers to the ENGAGES trial, you can see in itself that it makes sense to avoid burst suppression. And burst suppression, again, very easy to recognize in the clinical routine. When you induce your patient and look at the raw EEG, you can easily recognize it. It's these isoelectric phases in interchange with these alpha-dominant bursts and then followed by isoelectric phases. And you know, if you have done this, you have over-titrated, generally speaking, your patient in that situation. Easy to recognize. You don't need to be an EEG specialist to see that. Very easy to see and to adjust your anesthesia accordingly. And how to titrate your sedation part of anesthesia correctly. It's hugely helpful if you can take a look at the raw EEG under induction. Here we have different induction settings from 4 different patients. And you can see in the beginning you have the very typical beta dominant rhythm in all 4 of these induction scenarios. And when you apply the sedative part here, you can see the very typical changes from the beta dominant rhythm in all 4. You can see the changes into the delta waves with alpha waves cresting on top of them, indicating in all 4 settings that at that point in time that the brain is adequately disconnected in that regard, that you need to worry about the analgesic side, the ANS side, autonomic nervous system, that this is attenuated and pain is adequately taken care of. But you know at that point the brain is disconnected. Doesn't mean that it will stay disconnected if you don't continue your sedative part, but you can be fairly certain that the patient is deeply enough asleep for continuation, taking care of the analgesic side of the anesthesia. And overall, when you even include the engages trial, which you could also exclude or maybe even count as a positive study, you can still see in the meta-analysis that the recommendation for EEG monitoring or processed EEG monitoring in regard to the prevention of postoperative delirium, there's still an overall positive effect in regard to delirium, but also in regard to the prevention of POCD by using EEG monitoring. And this is how we use EEG as well as processed EEG monitoring in our clinic. I always use the raw EEG under induction, so to monitor the change from the beta dominant rhythm to the typical delta dominant with alpha waves on top of it. So I know this brain is adequately disconnected. Always make absolutely sure that your analgesic part is in place and your ANS control, that the patient is pain-free, because under intubation, obviously, this is a very potent pain stimulus. Then do not cause too much noise, so you can also use the raw EEG. Always cross-validate what you see in the EEG with your processed EEG number. So the less you experience, the better is you have an additional number for backup. If you have produced burst suppression, again, easily recognizable in the raw EEG, but also to be seen in the suppression ratio, but also in the suppression time over the whole period. Then you need to lighten up on the sedative part. Again, make sure that your analgesic is adequately in place. And then after the induction phase, then we switch to the DSA, where you can track the anesthesia over time. Also can allow to see how the patient most likely will wake up according to the end phases of the DSA. And most importantly, always use your own brain by all kind of monitoring that you do, that you make. Does it generally make sense? And are these numbers trustworthy? And that what you see, how does it relate to your experience? And of course, use as much information from the patient's brain as you can get in order to decrease the sedative and analgesic load on your patient in order to avoid these postoperative cerebral disturbances. Thank you very much for your attention. And if you have any further questions, don't hesitate. You can write to this email address, but you also can contact me personally if you're interested of knowing more or of communicating. Again, thank you very much.